webinar is sponsored by Zopec Medical. Zopec Medical is a medical leading manufacturer of lightweight medical grade UPS batteries that is designed for seamless patient transport, emergency backup, and supports medical operations, and as well supporting essential medical equipment that is used in patient care. It is also used for air transport, ground or medical transport, post-acute or rehab centers, home care centers, military, navy, and what have you. Now, when it comes to Zopic, what we say is we power critical care mobility with confidence. So that is Zopic. So if you are a company or an organization that wants to be a part of this innovation or this vision of the Africa Respiratory Care Association and would like to sponsor the Africa Respiratory Association's initiatives, kindly contact us on info@africaresp.org. That way, you would also be part of this great mission of promoting or enhancing respiratory care across the continent of Africa. So today we have all the way from Egypt. Yes, so Africa is made up of several countries. So all the way from Egypt, we have a great personality who has a Master of Science in Respiratory Medicine, and he studied it at South Wales, UK, and he is the CEO and founder of the Respiratory Gate and the Vice President of the Africa Respiratory Care Association. He is also the governor for Egypt in the International Council for Respiratory Care. And as well, he is an international fellow of the American Association for Respiratory Care. Without much ado, I present to you Muaz Mohammed Isam.
Thank you very much, Doris.
Muaz, thank you.
Hello, good
Muaz,
morning.
your audience, your presenter. Thank you.
Thank you. Good morning, good afternoon, good evening, wherever you are. Thank you very much for having me. And we don't want to delay more because actually this topic is going to be some sort of a complicated one, but hopefully at the end of this lecture, you will have a glimpse of knowledge about the heart-lung interaction. I'm going to just share the screen here. Just bear with me. Can you see it? Okay,
Yes,
perfect.
okay, yeah, sure.
Perfect. Thank you very much. Hello, everyone, and thank you for having me here today. And today's topic is going to be heart-lung interaction during mechanical ventilation. And actually, the thing is here that we don't need to talk about the mechanical ventilation effect. Also, we are going to speak about how the spontaneous breathing is going to impact the heart-lung interaction or the cardiovascular system. So I don't have any disclaimers, no disclosures or disclaimers to be declared. So today's objectives is going to be exploring how the physiology beyond the heart-lung interaction and focusing on the impact of the intrathoracic pressure and how the cardiovascular dynamics is going to change with everything that we have even during mechanical ventilation or with a spontaneous breathing. We will understand the clinical relevance of heart-lung interaction in critical care. I have few case scenarios here we're going to speak about and see how you are actually going to think about this. And we're going to explain how the positive pressure is going to alter the cardiac output and even the venous return, and what is everything of this, what is the venous return, what's cardiac output, and how this is really being impacted by the ventilation or the spontaneous breathing. At the end, we're going to talk about what is the role of the RT, the respiratory therapist, or the intensivist, or whoever the clinician is managing a patient, whoever on lung ventilation or on a mechanical ventilation, and need to understand what's happening with this patient. So let's go back to the history, and we're going to give a small historical background about how this cardiovascular interventions or interactions are being interpreted. So it goes back to the 18th centuries when Stephen Hawes, he was one of those started to discover how to the fundamental facts and the comparative physiology of the heart rate and the output. He actually has used the horses, the animals, to do his research, and he noticed that the level of the blood column in a glass tube, when he connected it to the carotid artery of a horse, was varying. And this actually made him, as the Emory University School of Medicine called him, the discoverer of hemodynamics. So with that said, we actually have the very first thing, or the very first lecture or literature that introduced the impact of the effect of the intermittent positive pressure on the breathing, on the cardiac output. And this was made by Dr. Andre Frederick Carnot. And Carnot had actually Nobel Prize in Physiology and Medicine in 1956. And if you can see here, this is his image, and the other one you have here, you have on the left, Andre Carnot standing and with William Besque, and he was seated. And this is one of the research they were being working at. And this was the very first thing that started to really explain what's happening whenever we're breathing, what's actually happening with our hearts. And with that said, I'm having here a case scenario, and I need you all to take a look into this. So we have a patient, Mr. A.S. He's a 68-year-old male with a history of diabetes, hypertension, ischemic cardiomyopathy, with ejection fraction of 25%. He is actually a chronic atrial fibrillation with rate controlled, and also a chronic kidney disease patient with stage 3. And he used to be a smoker with 40 packs years and stopped 5 years ago. And he presented to our ICU, actually to the emergency department, with increasing in shortness of breath. And over 3 days, he was orthopneic and leg swelling. He had a mild fever and a productive cough with yellow sputum. And when he was examined, he has a respiratory rate of 30, an SpO2 of 85 over 6-liter nasal cannula, a BP of 95 over 60, a heart rate of 130 with irregular rhythm. And he has a bilateral crackles up to the mid-lung fields with elevated central venous pressure with bilateral limb edema. This is one of the very complicated patients that you might see like coming to the ER and then goes up to the ICU. So the initial diagnosis was actually CAP. He was a community-acquired pneumonia on top of acute decompensated heart failure. And the investigation showed that he has alveolar infiltrates, prominent vascular markings, and with AF, and even with left ventricular end ejection fraction of 25%, with dilated left ventricle and mild RV dysfunction. This is a complicated patient, and you need to take a look into everything you're having here. Labs showed elevated BNP, creatinine of 1.9, and total white counts of 14 soudons, and the ABG showed a respiratory acidosis. So over the course of the ICU, we tried diuretics, empirical antibiotics, even home pipe or even BiPAP when non-invasive. However, patient become more distressed, and eventually he was progressed to mechanical ventilation. What do you think of this patient? What actually happened when this patient was intubated? His blood pressure improved. Whether you are thinking maybe this patient is gonna have a his blood pressure is going to decrease or not going to be doing good, but on the contrary, the patient blood pressure improved, heart rate decreased, ABG improved, and chest auscultation showed reduced crackles. I'm going to leave this question here, and we're going to get back to this question at the end of the lecture. So moving to the pulmonary circulation, and if we're going to speak about what's happening actually with the heart-lung interaction, we need to discover and to think about what's really happening. So to give a small review about the pulmonary circulation, it all starts from the right ventricle. Right ventricle pumps the blood into the pulmonary veins, and then the pulmonary artery, and the pulmonary artery is then going back to the left ventricle through the pulmonary veins. And this is actually what we really know. However, if you can see those lungs, they are kind of playing an interplay between the cardiac muscle and the lungs itself. They are attached to each other. So this is what actually happens. But do you think that if this pump coming from the right atrium, from right here, going up to the lungs, are they equally distributed inside the lungs? The thing is here, the answer is no, it's not. Because we have a gravity, and the gravity increases down. So if you have a blood flow of a patient who is standing, so we would consider this as the ABCs of the lung, and this is the mid lung, and this is the base. So this is the west lung zones, and they are actually describing how the gravity is impacting the blood flow and the ventilation, and how this is really going to change the pulmonary vascular resistance and what's going to happen with our patients. So what you have here actually is, this is zone 1 is represented by the ABCs, and if you have, you will have a alveolar pressure, the arterial pulmonary pressure, the pulmonary vascular pressure, venous pressure. So you have three pressures up there. But why does the alveolar pressure is more than the arterial pressure? Because the gravity, the answer is simple, because the blood flow is increasing down to the bases and decreasing up in the bases, up in the ABCs. So the alveolar pressure is actually more than the pulmonary artery pressure, that, and subsequently you will have the venous pressure, the pulmonary venous pressure is lower. Moving down to the mid lung, and I just need you to be focused here, because this is not the lung. We are trying to simplify it here, that the ABCs are the zone 1, mid lung is zone 2, zone 3 are the bases of the lung. However, if you change the position of this lung and put it on the side, you will have a different distribution of the blood flow and ventilation. It's not about zone 1 in the ABCs, zone 2 in the mid lung, and zone 3 in the bases. It's actually about where is the blood flow and where the ventilation really happens. And to look into this, you'll have the gravity is impacting the blood flow going down. So in the mid lung, you will have, yes, the arterial pressure is going more than the alveolar pressure, but still the alveolar pressure is more than the venous pressure. And you would see here that this is the alveoli sitting here, and you have the vascular pressure is here. The alveoli pressure is high, however, it's not compressing the vasculars as in the zone 1. So you have an increase in the pulmonary vascular pressure, however, not to that extent. And to be honest, we are targeting zone 2 whenever we are trying to ventilate our patients. So moving down to the bases, this is where the arterial pressure is going up, because imagine this, the whole blood flow is going with the gravity down to the bases of the lung, and in this position you'll have a high arterial pressure, and the alveolar pressure is going to actually less than the high arterial and the vascular pressure, and the alveolar pressure is very low. This is why you have the vascular kind of extended or dilated a bit. We're not going to delve into every aspect of the west zones, but you need to understand this, how the blood flow and the distribution is actually going to play a very pivotal role when we're speaking about the pulmonary vascular resistance and how this interact with the cardiac muscle. So this is zone 1, and you have here the collapsed alveoli, or sorry, the collapsed vessels, and you have here the mid zone of the lung. At the end, you have the distended vessels when the arterial pressure is going up. Sorry, the alveolar pressure is more than anything else. This is an undilate the vessels at the end of the zone. So we have three zones. Actually, we have a fourth zone, and it's the interstitial pressure, but we're not gonna get into this now. So going to the pressures and the pressure gradients, if you look into this picture, this actually one of the simplest thing that you can ever see, because we are speaking physics here. Nothing is going to happen to your lung, or your no airflow is going down to your lungs, no blood flow is going to your heart or getting back to your heart without any pressure gradients. And we have here the pressures. You can see multiple pressures. However, the pressure gradients are the one that we're looking to. And to be specific, I'm looking into the transalveolar pressure and looking into the transthoracic pressures. And we're going to delve into those very soon later in these slides. And also the transpulmonary pressure as well. Those a combined of pressure gradient between the mouth down to the trachea, the chest wall, the alveoli, the parenchyma, everything inside your chest is affecting the gradient between the pressures coming from the outside down to the inside. If you looked here, this is a schematic of the inspiratory and expiratory, inspiration, expiration in a spontaneously breathing patient. You can see that when the inspiration happens, the volume increases, the alveolar pressure decreases, and the airflow also decreases. The lower pressure decreases as well. And just we need to highlight this. Just keep this in mind, because what's happening whenever you're spontaneously breathing, your intrapulmonary pressure is negative, and also your interthoracic pressure is negative because you're breathing negatively. And this is what's going to affect the cardiac system later on. So without getting in more into the cardiac, or before we get into the cardiac system, you have to be aware that we have something called the transmural pressure. And the transmural pressure is actually, the mural pressure is the thing that is the difference between the pressure difference between the inside of the right atrium and the surrounding pressure of the thoracic cavity. You have here, this is the right atrium, this is the pericardium, and this is the chest wall. And the difference between the intra RA, the right atrium, and the intrathoracic pressure, this is called the transmural pressure. And you have to keep this in mind, because this is going to impact a lot of things and affect a lot of things when we speak about the heart-lung interactions later on. So moving to the cardiac and moving to the heart itself, before we move into how this pressure gradients is going to affect or impact what's happening actually inside the chest, you need to be aware of some of the concepts we know in the cardiac physiology. And first of all, the mean arterial pressure, and this is the cardiac output by the systemic vascular resistance, meaning that this is the amount of the blood is being ejected out of the blood multiplied by the heart rate and multiplied by the systemic vascular resistance, and this will equal the mean arterial pressure inside your body. So just bear in mind that we are speaking about systemic vascular resistance, pulmonary vascular resistance, and anything with resistance is actually going to change pressures. And this is what really controls the cardiac output. So the cardiac output is the stroke volume multiplied by the heart rate, and the stroke volume meaning that this is the volume of the blood being ejected during the systole, and the heart is just ejecting blood and it's going out multiplied by the heart rate. But we need to understand more about what really determines the cardiac output. It's not just the cardiac output itself. The cardiac output, we know it's stroke volume and heart rate, but what really controls it is the preload, the afterload, the contractility, and the rhythm. We are going to delve into two of those, and which is the preload and the afterload. Preload is simply the amount of filling, the filling of the blood. It's the volume of the blood in the ventricles at the end of diastole, and meaning that at the end of the resting state of the atrium, this is the volume that can enter the atrium, and this is called the preload. And according to Frank Starling law, increasing in volume, this will mean that will stretch the right atrium, and this will increase the force of the contraction. So preload can equally be filling pressure. So going to the other side, we have the afterload. The afterload is the resistance of the left ventricle. And resistance meaning when your left side is ejecting the blood, this means that it should go through the aorta, the vascular system. Whatever the resistance is facing this ejection, this is called the afterload. And I need you to be focused here, because the preload and afterload is not just for the left ventricle and the right atrium. It's also for the left ventricle, the right ventricle, and also for the left atrium. So there is also an afterload and preload to each chamber of the heart. But keep in mind, preload is filling, afterload is resistance. let's get into the heart-lung interaction. So the heart-lung interaction actually can be divided into two sectors and or two categories, one of which is the right ventricle interactions and the left ventricle interactions. And those can actually happen during inspiration and expiration. And during inspiration and expiration, is it during a spontaneously breathing or during a mechanical ventilation? The mechanical positive pressure ventilation. The positive pressure ventilation is going to change pressure gradient, and the spontaneous breathing is going to change pressure gradients. So keep in mind all the pressure gradients we spoke about, the preload and the afterload, because from now on, all we speak about is preload and afterload and how this really affect our patients. So let's move here. What you see here is actually a schematic of the interthoracic pressure here. As you can see here, this is the interthoracic pressure, and this is your heart, the RA, this is the RV, this is the LA, the LV, and start from the right atrium or the right ventricle, and how this can be impacted by only one thing, the negativity. We're speaking about a spontaneously breathing patient. And just to keep in mind that any change in lung volume is going to change the positive pressure or going to change the increase of the intrathoracic pressure. But is it the intrathoracic pressure or is it the intraalveolar pressure? And does the intraalveolar pressure transfers from the alveoli to the intrathoracic pressure and vice versa? We will know that later. But what we have here is a spontaneously breathing patients going here with an interthoracic pressure of negative interthoracic pressure. And we have here something else. You forget, whenever you're breathing, your diaphragm moves downward, and this movement downward actually creates a negative pressure inside the chest cavity, and also is going to increase the intra-abdominal pressure. And the intra-abdominal pressure is going to change a lot of things in when it comes to the backflow, or what we call the refilling of the RA. And we'll take a look into this now. So the RV preload increases. Preload, yes, because this is negative. There is nothing impacting here. The intra-abdominal pressure is increased, meaning that the backflow is going more from the venous return. This is going up because of the increase of the interthoracic pressure. This is going up, and then so this means filling increases. And the left ventricle output, we'll look into it right now. But this preload increasing is actually increasing in the filling, but is it during inspiration or expiration? We need to look into this. During inspiration, your negative chest wall is actually, the RV is getting more blood, or the RA going to the RV getting more blood, and then the RV stroke volume is going to increase. We spoke that the stroke volume, meaning that the amount of the blood ejected from the ventricle. If we have an increased filling here, we will have an increased ejection of the blood, meaning that the stroke volume is going to increase. But this is during inspiration. What's happening after that? Actually, when the blood goes from here during inspiration to go to the other side of the heart, there is something called the pulmonary transit time. And this takes around several seconds to impact the other side of the heart. So till the other side is being affected, is the LV filling is going to increase? Yes, because we have an increase in the stroke volume. Please keep in mind, we are speaking about spontaneously breathing patient. So the right side is affected by the inspiration, and the left side filling is affected by expiration. So whenever this negative pressure is getting into more positive, this LV is going to suction more of the blood. So meaning that we will have an increase in the LV filling, and subsequently we will have an increase in the stroke volume at expiration. I just need you to keep in mind, because this is maybe getting you more perplexed, or you will just lose it at any moment. But the thing is, here we are speaking about a theoretical physiological impact of what's happening in there. Is it really what actually happens? You can't say for sure, but this is what actually happens. So after this, so the preload of the LV is going to decrease, in inspiration is going to decrease, and eventually an increase in the LV afterload due to the negative intrathoracic pressure. I'm gonna answer every question you're gonna have. I know you have questions now. Just keep it in mind. We will speak about everything later. Let's talk about vascular resistance. And this is the other thing you need to keep in mind. And actually, when we are ventilating a patient, we need to understand something about the pulmonary vascular resistance. And the pulmonary circulation may be divided into two types of the alveolar vessels. We have the extra alveolar pressure and we have the intra-alveolar pressure or vessels, extra-alveolar vessels and the intra-alveolar vessels. If you look into here, you will have an alveoli who is having normal filling, is not putting any extra pressure on the wall, and this is the extra pulmonary vessel here. But when you over distend this alveoli, you're going to increase the pressure over this vessel, meaning that you're going to increase the total of the pulmonary vascular resistance. Just keep it in mind, pulmonary vascular resistance, meaning the resistance in the pulmonary system coming up from the right side and going up. So you have here a schematic or a diagram we're having here. This is the pulmonary vascular resistance going up, and here you will have three different lung volumes. This is the residual volume, and this is the volume that you cannot expirate. This is the functional residual capacity, and for all respiratory therapists in there, I just tell it all the way. We ventilate our patient to add their FRC. This is the functional residual capacity. This is the moment, this is the place that we are targeting when we are targeting ventilation for our patients. And when we over distend our alveoli, we are getting more into the total lung capacity. We are over distending the alveoli, meaning then the extra vessels is getting more of the pressure putting here, getting the pulmonary vascular resistance up, and so happens, and the thing happens for the alveolar vessels as well. So you need to understand what's really happening in there, because I'm going to tell you later on, we have a patient who is ventilated on this, on a pressure of that, and his interthoracic pressure is getting up. And do you think that his preload is going to be affected or impacted by the pressure we're putting or not? If the patient is over distended, definitely your vascular resistance is going up. So increasing in the lung volumes at the inspiration increases the radial interstitial forces that you are putting on the vessels. This will widen the extra alveolar pressure, the vessel's diameter, and eventually you will have a pulmonary increase in the pulmonary vascular resistance. And this is called the mechanical vascular compression. And those are two types of the why we have pulmonary vascular resistance. We have two types or two categories. The first one we explained already, the mechanical vascular compression. And we have another thing, which is the hypoxic vasoconstriction. All of you may know that, yes, hypoxemia or hypoxia can cause a vasoconstriction. But how this actually happens? This actually happens by the endothelium that excretes the nitric oxide is being affected by the hypoxia, and the nitric oxide is a vasodilator, and this what happens. And whenever you are affecting the endothelium is not excreting nitrous oxide as much, so the vessels are getting more vasoconstricted or getting more narrower. So the other concept we need to understand is, does really the heart affected by itself? Is it really a venous system, a right side and a left side, and they are not talking to each other? No, the thing is here, they are in the real chamber and they are in the same chamber and they are sitting in the same room. They enter the chest wall, the cage that they are sitting at, and they are all affected by the same pressures. However, there is a theory, and it's not just a theory, it's actually a very interesting topic, which is the ventricular interdependence. And this means, and in the ventricular interdependence, if you can see here, any change in the filling pressure that will affect the one volume, or the filling pressure or the volume of one ventricle can be affect the ventricle, the performance of the other ventricle. Just going to show you something here, because this is going to show you. Just bear with me a bit. Yes. So the right ventricle output here, you can see here, this is the right ventricle. So the right ventricle output is linked to the left ventricle output, and they are connected serially. Serially, so this pumps the blood out, and this blood is going out to the other side, and they are actually connected parallelly. And so serially, if the right ventricle output decreases, so the left ventricle output must eventually decrease. And the two ventricles here, however, are also linked parallelly through their common septum. This is the septum they are having, the circumferential fibers, the pericardium they are having in between, and this will limit the total cardiac volume and subsequently the cardiac output. For the reason, the diastolic filling of this RV has a direct influence on the shape and the compliance of the LV. So they are talking to each other and so forth. The LV is doing the same. So during inspiration, you are increasing the end diastolic RV pressure, pushing the left ventricle to the other side. During expiration, the LV is doing the same. And this is a schematic done here. And you can see how the difference is happening and the change of the RV end diastolic volume to the change of the LV diastolic compliance. So this is the LV pressure, this is the left ventricle volume. So whenever you increase the right ventricle volume, see what happens. So you increase the left ventricle pressure. So the right ventricle volume is subsequently or connected directly to the LV pressure. So whenever you increase this, you increase this. So for this reason, the diastolic, this phenomena is actually known as the ventricular diastolic interdependence. And the most manifestation of this ventricular affection is called pulsus paradoxus. And pulsus paradoxus is actually when there is an inspiration, there is a change in, or when the inspiration happens during the systole change, systolic pressure change by more than 10 millimeter mercury. And this is happens actually, it's a phenomenon, it's there, and it's called pulsus paradoxus. So you have the RV talking to the LV is talking to the RV, the end diastolic volumes is changing subsequently to each other. So we have now identified what's happening with the cardiac filling and what's happening with the pulmonary vascular resistance. Patient have a negative preload, negative pressure to load. Distance is the stroke volume, as we said. This transit time we are having is going to change. We're increasing the LV filling at the expiration. The stroke volume as well is going to increase. And eventually, the LV preload is going to be decreased. So we have an increase in RV preload and afterload. The LV preload is going to decrease. And the preload, I mean here, the filling, and here's the resistance going to increase. And keep in mind, spontaneous breathing patient, the LV afterload will definitely increase. So moving to the schematics, this is a very, very nice schematic simulation model done by Nicholas and colleagues. And heart-lung interaction in this patient, he showed how the interaction happens in the whole body, and they draw this kind of schematic seam. And you can see here, this is the heart, this is the pericardium, this is the whole chest wall, the thoracic cavity, and this is the abdominal pressure that's going up to the thoracic veins. Thoracic veins is going to get the blood up to the right atrium, down here from the right atrium to the right ventricle. This is the patient, so this will be pushed down to the pulmonary artery, pulmonary arterioles, going into the capillaries, the extra alveolar vessels, the intra-alveolar vessels, pulmonary shunt according to the west zone we are targeting and the pulmonary vascular resistance we're having. Pulmonary veins get back to the left atrium and then to the left ventricle, going down to the systemic arteries. And all of this inside one chest cavity called the thoracic cavity. Keep this in mind, because what's happening in this whole lecture is what's happening in there, because this is a negative pressure whenever you are spontaneously breathing, and it's going to change very soon. Let's talk about how the mechanical ventilated patient is going to be affected. So we actually explained what's happening whenever you're spontaneously breathing, but what's happening during mechanical ventilation is the whole other thing. So you have here the interthoracic pressure definitely is going to increase. You have your ventilator set up for a pressure control mode, a volume control mode, or whatever the mode you're using. You are increasing the intra-alveolar pressure, and the intra-alveolar pressure is going to subsequently increase the interthoracic pressure. But is this what's actually happens in all patients? We will know later. And whenever you're increasing the interthoracic pressure, definitely the pulmonary vascular resistance will increase. But let's see here. Is the venous return being affected? Yes, it is, because you're having here a chest wall that has a positive interthoracic pressure that will push the veins coming from down a little bit, so it will be narrowed, so the filling is going to decrease. Subsequently, the preload is going to decrease. But we remember that we have the diaphragm, and the diaphragm is going to contract down, increasing the intra-abdominal pressure, and the intra-abdominal pressure is going to increase the backflow. So not every patient that you set on the mechanical ventilation, the RV filling is going to decrease. It's not going to happen in all patients. It's not going to happen in any patient. So we have an interthoracic pressure. This will increase that. This will increase that. However, you have different type of compensatory mechanisms that will compensate for the venous return, and the the right ventricle is actually, the preload might not be affected as much as they think. So the stroke volume is going to decrease if the preload is decreased. Where, let's say that we are having a preload dependent patient who is hypovolemic, he is not having as much fluid in his body, so this is going to decrease the stroke volume, meaning this small filling, meaning small stroke volume, and the RV work is going to push more of the blood, because the end diastolic volume is going to change and the RV afterload is going to increase. And then when this increase, the pulmonary vascular resistance increase. And this is on the side of the RV on the right side. But for the left side, we can remember the ventricular interdependence. If the LRA and the RV are getting down, the LV and the LV stroke volume is getting down as well. But however, the interthoracic pressure, the positive interthoracic pressure, is going to change the LV afterload, because the LV afterload is the only thing is going to decrease, meaning that the ejection of the blood coming out of the heart is going to be more, compensating for the other side. And just keep this in mind as well. So in positive pressure ventilation, LV afterload decreases, meaning maybe your cardiac output might be affected. If we are speaking of this case specifically, and this actually happened, that this patient blood pressure is going down and everything is going down, and this patient's heart is and hemodynamics are being affected, eventually your cardiac output is going to go down. But don't forget, not every patient we place on the mechanical ventilation is going to be affected on this way. Let's go into the heart-lung interaction case scenarios. And I really love this scenario because whenever you're saying intrathoracic pressure, what comes in mind is PEEP, positive end expiratory pressure. But let me ask you a question. Does all the alveolar pressure getting into the pleural pressure and the intrathoracic pressure? The thing is here, in ARDS patients, the lung compliance is very low and the collapsed alveoli cannot transmit pressure. That's why when you place a patient on APRV, or which I really disencourage, and when you place a patient on any high PEEP like the RDSNAT, you're placing higher PEEP, lower tidal volume strategy. You are thinking of this is a very high PEEP. This patient blood pressure is going down. But when you do so, this actually never happens. What actually happens that your patient might have an improvement in the blood pressure. So why this happens? Because when you ventilate a patient and you put a high PEEP, if it's a collapsed alveoli, this PEEP is not going to be transmitted to the intrathoracic pressure. But if this PEEP actually recruited alveoli, this lung compliance is going to be getting better. This is going to be everything is getting better. Your alveoli is getting recruited, meaning that the pulmonary vascular resistance. Remember, you are having a collapsed alveoli. This is in the if you can think of the west lung zones, you're having a collapsed alveoli and you're having this kind of blood flow ventilation mismatch and ventilation perfusion mismatch. In ARDS, the low lung compliance limit the airway pressure transmission. The beep decreases the hypoxic vasoconstriction subsequently and the pulmonary vascular resistance. And this will actually improve the RV afterload if the alveolar recruit dominates. Meaning that if you're having an alveoli that's being recruited, meaning that the pressure putting on side the intravascular pressure or the pulmonary vascular pressure is going to increase, meaning that the RV afterload is going to improve. So what do we have? Do we have any risk doing this? Yes, over distension. Remember, you're having an intravascular vessels and intraalveolar pressure vessels and the extraalveolar vessels. And when you put an extra pressure on it, they are actually increasing the vascular resistance, meaning that your RV is being strained. It's not pumping blood, or it's not the preload is affected. So the cardiac output subsequently is going to decrease, and the systemic venous pressure, the venous return is going to decrease as well. And this is due to the increase of the intrathoracic pressure. And definitely the RV afterload is going to increase. I know it's a lot of data to digest. It's not that easy to understand. However, just keep in mind, it's all about the filling and the resistance outside and what's happening inside the vessels. So this is for the ARDS. But what about the clinical application in the left heart failure? And left heart failure is actually one of those kind of diseases that is being improved whenever you place patient on PEEP. And that's why this benefit of the positive pressure ventilation is gonna improve the left ventricle preload, because when you place a positive pressure ventilation, in acute heart failure in the acute left ventricle, your preload is going to decrease, and that's because the transmural pressure, the right atrial pressure, is going to increase. And this is in the HFpEF, the heart failure with preserved ejection fraction. This is a preload dependent heart. And keep in mind, we have two types of dysfunctions: a preload dependent heart and a preload and afterload dependent heart. And in the HFpEF, the preserved functions we have might not improve everything regarding the left ventricle. However, the afterload, remember, positive pressure, meaning in the intrathoracic pressure is positive, meaning that the afterload is going to decrease. And you can imagine that when you place your patient with acute decompensated heart failure, when it comes to the ICU, and you decide to place the patient on the non-invasive ventilation, what happens after this is impressive. You just place the patient, Your patient is getting work of breathing is decreased, hypoxic vasoconstriction is decreased due to the improvement of hypoxemia, and everything is getting better, and the patient is getting better. That's why, because you are relieving the left ventricle ejection fraction. You are removing some of the strain or some of the force that is going to be exerted by the left ventricle to pump this blood. Another thing to bear in mind is the myocardial ischemia. And myocardial ischemia is actually the oxygen supply is getting, with the better oxygenation, will decrease the left ventricle end diastolic pressure, and hence the coronary perfusion is going to improve. And when you decrease the oxygen demand, the work of breathing is going to reduce, and the respiratory muscle is going to get better, blood flow is getting better, and everything getting better. So whenever you have a left ventricle heart failure patient with reduced ejection fraction, this patient is going to be improved on the with the positive pressure ventilation. So, and eventually at the end, we have one more thing to before we end this lecture, and which is, why do we have a failure in weaning from the mechanical ventilation in patients with left ventricular diastolic dysfunction? The filling pressure are common in the weaning failure, because whenever you are removing this positive pressure in the interthoracic, remember, increasing interthoracic pressure, decreasing in the afterload in front of the left ventricle. So if you just reverse this and you place the patient, make the patient interthoracic pressure negative, this will increase the afterload in front of the left ventricle, and subsequently this patient might get into pulmonary edema. And it's a significant thing we see with a lot of patients we have in the ICU. It's happening. This patient, just keep in mind that the positive and negative pressure, this shift between both of them will change the afterload and the preload of the heart, and the cardiac work can increase, and the pulmonary congestion could happen. And you get back to the ventilation back again. And once you connect the patient to the ventilator, everything is getting back again. So the weaning from mechanical ventilation failure is a multifactorial thing. You need to think about it very critically. And this may include, you could ask for the cardiology to come for an echo study, your hemo concentration markers, and any management that could improve the weaning and success. So this kind of patients we consider a high risk patient whenever we're extubating them, and you should bear in mind and keep this in mind, that what's happening inside of the chest wall is really affecting your patient's life. So what should we do to limit and overcome detrimental heart-lung interaction? So it's simple as that. Minimize the work of breathing. Work of breathing means increase in the pulmonary vascular resistance due to the hypoxemia. Just reduce the airway resistance, and the collapsed alveoli recruited, and everything will be good. Prevent the hyperventilation. We just approved that any increase in the interthoracic or any increase on the alveoli, the overdistension is going to impair the intra-alveolar vessels, and this subsequently will increase the pulmonary vascular resistance and the embedded cardiac filling. So the venous return is going to be affected, and eventually you and the team in the ICU just keep in mind that volume overload on left ventricle diastolic dysfunction patient is going to affect the patient spontaneously, and this must reduce the interthoracic pressure, increase the oxygen consumption. Keep in mind, oxygen, the left ventricular dysfunction is a patient who is afterload dependent. Any patient with afterload dependent is really dependent on the positive pressure inside the interthoracic pressure. And in summary, let's take a look into this. And this is the diagram. And this diagram, it's actually, this schematic shows that the increase in the preload will increase the filling. Yes, the stroke volume is getting up. Yes, transit time to get to the other side. The left filling at expiration is different and goes to the other side. This is for a spontaneously breathing patient. This is for a mechanically ventilated patient. It's what actually is it's the reverse of everything. But however, when it comes to the afterload, the LV afterload is going to change and decrease on the mechanical ventilation, and this will increase the the filling of the other side of the heart, maybe in the lung, in decompensated heart failure with left ventricular heart failure. This could actually help our patients get better. So getting back to the case scenario, and yes, we are having this patient, and look into the ICU course. This patient, whenever we place the patient on a positive pressure ventilation, patient is starting getting good, blood pressure improved, heart rate decreased, ABG improved, everything is getting improved. And this is because this patient is a left ventricular ejection fraction of 25%, dilated LV, meaning that this is a decompensated heart failure, left side, meaning that this heart is an afterload dependent heart, meaning that it's going to be improved by using any intrathoracic pressure or increasing of the positive pressure ventilation. And so the patient had a left-sided heart failure, primary issue exacerbated by the infection, the CAP that we said, the AF with the reduced ventricular, and the positive pressure ventilation improved the cardiac output, yes, because the LV afterload and preload has decreased, yes, and the hypoxemia has reversed, the AF and the rate controlled, and everything get back to normal. We learn from here that the acute decompensated heart failure can be triggered by infection and is being managed by the positive pressure ventilation. And we really need to monitor the renal functions and volume status for this patient post intubations. So thank you very much for having me. I hope this makes sense for every one of you. And if you have any questions, I'm here.
Was Mohammed, and thank you for the presentation. Please post your questions at the Q&A session. If you can't find the Q&A, just click on more on your Zoom button below. You see Q&A. That is where you have to post your questions. So kindly post your questions and then we'll read them out to Moaz. Thank you. And if there is time, we may open the floor for some verbal questions. But for now, we will take Q&As.
I hope everyone understand everything, because it seems that no one has questions.
No questions will come. And also, if the aspect that Moaz taught today is one of the aspects that respiratory therapists do in the ICU. So those are the things that we do in managing the patients that are presented in the intensive care unit. So this and many reasons are the reasons why the African Respiratory Care Association has been formed to promote this profession across the African continent so that every country in Africa would have respiratory therapists. So imagine every country has a respiratory therapist or respiratory therapy team in that country. We could minimize the burden of respiratory care diseases. So you would have to support us. You have to be a member of the Africa Respiratory Care Association. And if you are an organization or you are an institution or you are a stakeholder, kindly reach us on info@africaresp.org. That way we can discuss further with you on how you can also contribute to this all life-saving initiative that we are bringing to Africa. So kindly post your questions and then we'll read them out to you.
Maybe if you don't have any questions, if one of you have, like, one of your patients has different interaction, make it heart-lung interaction, and you have a story or an experience with any patient, you could share with us. This is going to be great.
Yeah, so on that note, you can raise your hand, or if you have your question and you can't say it out
There are
loud, you
many
can type it.
questions in the Q&A already.
Okay.
I can't see them. Are they? Can I
No,
see them? Or
no, it comes to us. We'll read it out
all right, okay.
to you. Okay. All right, so I'll let the IT personnel start and then I'll take it from there.
Okay, so Mr. Moaz, your first question is, how can not all patients how can all patients be affected the same way on vent regarding BP and cardiac output? How come not all
Sorry, I didn't.
patients will be
Again?
affected the same way on vent regarding BP and cardiac output?
I hope I get the question right. So you're saying that the question says that the different patients are not affected by the same.
Yeah.
And back to yeah. So yes, they are not affected because it's actually depend on the whether your patient is a cardiac dependent, preload dependent patient and has an RV issue or a left side issue, because this is the thing we're having here. Remember, we have compensatory mechanisms for every patient. Every patient has his own compensatory mechanism. Their body's trying to compensate for the RV filling. And if the RV filling is not the issue here, it's on the left side with any left side decompensation mechanism. This will have the impact. It's all about the preload and the afterload. And believe me, it's not a white and black thing. It's really gray area, and you really don't know. What I really hope by this lecture for every clinician here is to think about, when you are ventilating your patient, why does this patient, whether increased in the blood pressure or decreased in the blood pressure, you have to understand the physiology beyond this. You need to know why this happens. Actually, you could have one of the new things that you could use is the pulse pressure variation. And the pulse pressure variation is one of the methods we're using to know the fluid responsiveness with every breath. So it's really affecting our patients. We really need to know what's really happening and what happened inside the chest wall. Is it really what happened? This patient is his heart rate decreased and the cardiac output decreased and everything. Is it due to the intrathoracic pressure or is it any other thing else?
Okay.
Okay, so Mars,
Mars,
thanks for
thanks for
the
the
great
great
and
and
valuable
valuable
webinar. That's what Maha is saying. And
and
if
if
you
you
can
can
hear me,
hear me
say,
say,
from
from
your
your
experience,
experience,
what
what
are
are
the
the
most
most
practical
practical
bedside
bedside
tools
tools
to
to
assess
assess
lung
lung
heart
heart
interaction
interaction
in
in
the
the ICU?
ICU?
There is actually no specific tool that you could use to know the heart-lung interaction, but whenever you are ventilating a patient, you should know the pathology before you do it, because you should expect that your patient, whenever you induce the anesthesia and you give the sedation for the patient, you should expect that this patient cardiac output is going to decrease because of the sedation and the hypotonia is going to happen. But is it because of you are increasing the interthoracic pressure or decreasing the venous return, or is it because the patient is having some sort of heart failure? And there is no tool that can says this patient is having a very bad heart-lung interaction. But what you could do is decrease the work of breathing and assess your patient properly.
Okay, thank you.
Darren
Darren
is
is highly
highly
informative,
informative,
and then
and
he
he
also
also
said
said
it's a
it's a
great
great
Sorry,
lecture.
Dorothy, I'm sorry, but the voice is echoing.
Is
Is
it
it
better
better
now?
now?
No.
Is
Is
it
it
better
better
now?
now?
No. The
I
two
could hear you.
directs are on mute one.
Okay. Can you hear me? Can you hear me?
We
Is
can
it
hear you,
better?
but you're echoing.
Oh,
Oh,
okay.
well, maybe
Maybe
the
the
IT
IT
would
would
work
work
for
for
that.
that.
Are you able to mute one of your?
Yes.
mute one
But
because
yeah, you could ask the question. I will try to understand it.
Is it better now?
Yes.
absolutely.
Okay, good. Sorry, we had technical problems here, but it's okay. Okay, so Darren said it's highly informative. And then he also said it's a great lecture. And then we have from Menatula Ahmed, who says, how come not all patients get affected the same way on vent regarding the BP and cardiac output?
Sorry, come again because I didn't hear the last
He says,
part.
how come not all patients get affected the
Yeah.
same way on the vent?
The patients are not affected the same way because of the compensatory mechanism. This is the first thing. The second thing is the ideal body weight of the patient and the mass index of the patient himself maybe is impacted or not, or affected or not. And also, if the patient having any kind of hypovolemia or any other issue, it's actually about the pathology. It's not about the patient. The two patients have the same pathology, same everything. They might have the same decompensation, but yes, it's different because no one has the same pathology, and you have different manifestations of many diseases happening in this patient. As the patient we have in our lecture, this is a patient is coming with a acute decompensated heart failure, with patient who is also a CKD patient, meaning that his urine output might be decreased. You're having a left side heart failure with multifactorial things. So it's not going to affect patients with the same way. Not everything. What we really have to do is to manage our patients, follow up the patients. After the induction of the sedation, this is going to change a lot of things. Whenever the patient is stabilized, just monitor the patient, see if there is any affection, monitor the fluid status of the patient, see if this patient is really fluid responsive. Is he or she a hypovolemic patient? This what's really important. What's really important here, because patients just differ. They are not the same.
Okay, thank you. All right, so an anonymous question. I said, what is our role with patient, in managing patients with cardiac problem? When you say our role, please kindly specify your professional background. Then we can know your.
Okay, perfect.
If it is respiratory therapist,
as a respiratory therapist, your whole sole thing that you should do in the ICU, you should not have a patient with an increased work of breathing. You should know, you should assess, you should give the patient the right administration of medication. I'll discuss with the team. You should know if this patient is requiring. We discussed the spontaneously breathing and the positive pressure ventilation. In the spontaneously breathing patient, he might have an increase in the work of breathing, increasing the pulmonary vascular resistance, meaning that this patient cardiac muscle might be affected. So decreasing the work of breathing is your 100% goal in the ICU as a respiratory therapist. You should just monitor your patient. You should not have a dyspneic patient with any patient with dyspnea or tachypnea inside the ICU whenever this ICU is having a respiratory therapist. You should know what's happening with your patient. You should administer the right thing. You should follow up the patient. And following up is the key here in the ICU.
Okay, thank you. Okay, this is an anonymous person says this is a really interesting topic, such an amazing talk. Thanks, Moaz. He says thank you. And from Menatula Ahmed, he says, so is there possibility for the BP to increase on vent rather than decreasing?
Sorry, the question again?
Is there a possibility for the BP, that's the blood pressure, to increase on the vent rather than decreasing?
Rather than the left side heart failure, you mean?
No, it wasn't specific. But with this question, said, is there any possibility for blood pressure to increase whilst the patient is on a vent? This is on the general question.
Anything that will increase the stroke volume, that we know cardiac output is a stroke volume, but the heart rate, anything that will increase the stroke volume, anything that will enhance the ejection fraction of the cardiac muscle, this will increase the blood pressure. So blood pressure is not gonna be affected unless this patient is severely impacted and his heart or her heart is not functioning properly. So you could have a patient, an ARDS patient, whenever you place the patient on the ventilator after you intubate them, you just don't have any affection on the patient. You might have a patient with, you're placing a patient on a 15 of PEEP of 15, and you having the blood pressure is not affected whatsoever. And this is different because nothing is going to increase the blood pressure unless you use the equation. Blood pressure meaning that the cardiac output is different, the stroke volume is different, it's going increasing, so you should target this. So no, there is nothing specific to say this will increase the heart rate or increase the blood pressure, or this is not going to
Okay.
increase the blood pressure.
Okay. So from Seth, he says that was a good one. From what I heard today, so which means from what he heard today, pulmonary vascular resistance does not really get bad on that's a bad impact on ARDS. Now, his question is, now, is it the same case for all other restrictive or lung parenchyma conditions?
Not really, actually, because in COPD patient, it's in the contrary. Because in COPD patient, you have an hyperdynamic inflation of the lung, and this hyperdynamic is actually increasing the pulmonary vascular resistance more than the ARDS because your alveoli is already distended, and they are placing some sort of pressure on the intra-alveolar vessels, so the PVR is going to increase as well. So it's different. The parenchyma is different. You should, that's why this lecture is important, because it's not about the pathology, it's about understanding what this pathology can actually does to the heart lung and the interaction between one of them.
Okay. All right. So from an anonymous person says, what's your recommendation or the recommended settings and mode for such patients to benefit?
Nothing specifically. I'm not this kind of guy that says this mode is actually better than this. However, you should individualize your therapy to the patient. Individualizing of your therapy is a very important whenever you are having a patient. Pressure control, volume control is not going to different. Whatever increases the intrathoracic pressure is going to decrease or is going to affect the pressure gradients inside your heart or inside your chest cavity, and this will affect your heart eventually. So you might see this as a decrease in the cardiac output and the blood pressure, but there is something actually happening because physiology says so.
Right. And from SOBA, it said, we had a patient who goes hypotensive and bradycardic on a volume control mode, but vitals were stable on pressure control mode. Chest X-ray showed cardiomegaly on presentation at the ED. Please, why does this happen?
Actually, I don't know. I don't know because
Yes,
I don't know
every
because
patient
we need
different
more data about the patient,
information. Yeah,
more info. Yeah, but
yeah.
eventually cardiomegaly is an increase in the muscle, the hypertrophy of the muscle itself, and hypertrophy meaning that the transmural pressure is going to be affected inside your heart because a transmural mean a transfer of pressure or a pressure gradient between a wall and the other part outside this wall. Because if you have a cardiomegaly patient, meaning that you're hypertrophic lung, and this hypertrophy is going to affect the transmural pressure, meaning that your RA, the right atrium, is not going to receive much blood, meaning that your heart, the RV filling is going to be decreased, the stroke volume is going to be decreased, so your cardiac output might decrease. I don't know if this what actually happened in this patient, but I think this is the educated guess I could give you.
Okay, but before I go to my last two questions, as you can see on the screen shared, we have a survey which is being conducted by the Africa Respiratory Care Association, and the title is Validating or Validation of the Respiratory Therapy Profession for African Healthcare System. Now, what this survey is all about is that this is not for you, the respiratory therapist watching me today. This is for the non-respiratory therapist health personnel. We want you to click or scan this survey and validate us. We want to find out your view about that. Do you think we need such a profession in your country? So there are some questions, basic questions in the survey that we want your opinion on. So kindly scan the QR code that you see on your screen. If you are a French speaking person, we have it translated in French as well. And then we have English. So kindly scan and then join in the survey. Now, let me continue with the last two questions. It says, this is from an anonymous participant. It says, if we had a ADHF patient, the most preferred ventilation mode is VC with modifying the parameters to match the patient's needs. What is it? I think the question is just like
I don't think if it's a question,
yeah, it's
there
a
is
question and a
no
comment.
consensus. There is no consensus what to use in any patient with acute decompensated heart failure. There is no consensus on any mode on the whole planet globally. You should use this in front of this. You just weigh the benefits for your patients, know what really actually work for the patient, choose the right parameters, do what actually the patient needs, and this what really gonna, you can get the same parameter on pressure control, doing it on volume control, do it with any dual mode, use any mode that will decrease the work of breathing without any desynchrony between the patient and the ventilator, and you are on to go. You are just doing right. This is the if you, unless you're having an inside protocol inside your institution, this is a different thing. However, consensus wise, literature wise, personalize your therapy, please. Personalize your therapies.
Okay. Thank you very much once again, Mr. Moaz, and thank you, dear audience.
Thank you, everyone. Thank you. Have a good
Yes.
one. See ya.
Yes.
Bye
So,
bye.
bye-bye.